from the American Academy of Pediatrics.
Incorporating trauma-informed care into our pediatric practices can at times seem overwhelming.
A new hands-on guide offers resilience-based interventions to build early relational health.
The opportunity is to move out of a model where we are a one-way information flow, just telling parents what to do, but actually instead showing them how to do it.
Plus, artificial intelligence is already a part of pediatrics. How can we be sure to use it responsibly?
The reason that we are able to use these tools as pediatricians is because we are the content experts. All the concerns we have about these AI tools not being accurate, they are not important when a content expert is reviewing the output.
These stories and more on Pediatrics on Call, the podcast on children's health from the AAP. I'm Dr. Joanna Parga-Belinkie.
And I'm Dr. David Hill. This podcast is for everyone in the medical community, keeping our children healthy and safe.
It's a show by pediatricians for pediatricians.
But anyone who cares about kids will get a lot out of it as well. Let's start today's episode with a conversation about helping families build healthy relationships.
People often ask me how I can practice neonatology because being in the NICU itself is a trauma, so I'm meeting families where they do not want to be. That's how our relationship starts, at the center of this traumatic event.
You know, that's a really profound observation, Joanna. It's one of the reasons that I pursued primary care pediatrics and decided not to become a neurosurgeon, which was my first thought, because we all experience trauma in our lives, and it can be so hard to embrace joy in a career where babies and children are constantly in crisis.
Yes, but so many of us, David, became pediatricians because we wanted to help. We wanted to connect with families, to help them thrive. I think there is a world where we can address trauma and still find joy, love, and connection with each other and in our jobs. I've seen it in my world in the NICU, and when you can find the threads of relationship, even in a terrible situation, the healing power is endless.
You know, Joanna, you just made the NICU sound sort of magical. And that magic is something we need in pediatrics and on this podcast. So let's invite another magic pediatrician to the show, Dr. R.J. Gillespie. Dr. Gillespie is a pediatrician with the Children's Clinic in Portland, Oregon, and consults in the fields of quality improvement and primary care-based screening.
Practicing trauma-informed care, almost by definition, cannot be done alone. So, with Dr. Gillespie, let's also invite to the show Dr. Amy King. She holds a PhD in psychology and is a licensed psychologist in Portland, Oregon, who does training and consultation around early relational health. Doctors Gillespie and King, welcome to the show.
Thank you. Happy to be here.
Hi there. Thank you.
So, Dr. Gillespie, can we just start by defining early relational health? What are we talking about there?
Sure. I'm going to start by talking a little bit about social emotional health and then how early relational health relates to that. Because I think people are a little bit more familiar with the idea of a child's social emotional development, which roughly speaking is a child's ability to form relationships, experience and regulate their emotions, and explore and learn. So social emotional health is the child's perspective on what's going on in their development. Early relational health, though, really reflects the fact that a caregiver has to give the context for how that development happens and how that emotional regulation happens. And so early relational health is really that bond, that attachment between a loving caregiver and their child that helps a child to achieve that social emotional development.
And does it also help a child to achieve resilience? How would you define that, Dr. King?
Yeah, I think the word resilience has gotten a bad rap lately, to be honest, and often people confuse resilience with grit or perseverance. But big picture, resilience is the ability to adapt or to overcome a stressor or adversity and to be strengthened by it versus challenged. The key here, especially when we're talking about early relational health, is that resilience is relational. You learn how to be resilient through the relationships in your life. So if you don't have safe, stable, nurturing adults in your life who are showing you how to overcome adversity with healthy coping mechanisms, you really aren't building those resilience bones.
And since you brought this up, what barriers exist for pediatricians who really want to address childhood trauma in their offices, but find these concepts difficult to achieve?
I think for me, many clinicians, when they're presented with the idea of trauma-informed care, it is really a philosophical process where you're really thinking about, are we aware of trauma? Are we aware of its impacts? And that, thinking about how the things that we are seeing in our office may be the result of trauma. But we're not often given very concrete steps in terms of what we're doing differently in our day-to-day practice. And so I think that moving trauma-informed care from that sort of conceptual framework into a practical framework is what's really missing in the lives of clinicians. Now, the AAP has taken the position that trauma-informed care is relational health care. And so one of the practical moves is actually to start supporting responsive relationships in our practice. So what can we do to make sure that that supportive relationship is thriving between a caregiver and a child? And that's really where I think the rubber meets the road in terms of being practical about trauma-informed care rather than just aware of trauma and its effects.
I would add something too. I think that often having a trauma-informed practice feels like an extra thing, but we really want to encourage pediatricians that they're already doing so much around anticipating needs for early relational health, and it can really be enhanced. It's things that are naturally occurring, and sometimes it's just a matter of naming really positive interactions and then strengthening ones where we see gaps to help that caregiver understand why this is important, what they can do about it, and how they can really use relationships to build resilience, which we know is what mitigates stress and trauma.
I love these observations, especially because so many busy providers in practice do not want to hear that they need to spend more time than they're already spending. So maybe let's start with you, RJ. As a practicing pediatrician yourself, give me like an example of what you're doing in your own practice to make this happen.
Sure. And I think one of the opportunities that we have as clinicians is to transform some of the things that we're already talking about in our anticipatory guidance into what Amy and I call 100 little conversations about relational health. So traditionally, for example, in our anticipatory guidance, we might talk about healthy eating or make sure you eat your broccoli. Instead, what we encourage people to think about is, what are you doing together as a family around meals? And what are you talking about at meals so that you actually have some routines and some structure that help with relationship building? So I always use the example of my goddaughter's family. They, from the very beginning, had a dinner time ritual where they talked about highs and lows. So at the dinner table, everybody would talk about something great that happened in their day and then something that was challenging. And what that did is it gave people an opportunity to not only share things that were exciting or happy in their lives, but also the children get an opportunity to troubleshoot things that are more challenging with their parents and have that kind of opportunity to fix problems as they come up. So again, rather than just talking about healthy eating, talk about dinner time routines and rituals and what sort of things you can talk together about as a family. And that turns a normal anticipatory guidance subject into a resilience building opportunity or a relationship building opportunity. And so hundreds of little conversations like that over the course of a child's lifespan will help to build those relationships over time.
So that seemed to be one example of 100. Amy, can you expand on this concept a little bit more to give us some more ideas about how we can teach families to build strong relationships with each other?
Yeah, I love the example that RJ gave because we don't want clinicians to feel overwhelmed by this, right? When we look at the research that shows how we mitigate stress and trauma, being able to talk about feelings, having a whole village that's supporting you outside of your family, there are lots of little tools that we can give clinicians. One thing that I'm really big about is telling them you don't have to be a therapist to be therapeutic, right? So many pediatricians get worried like, oh my gosh, Amy, I'm not you, I'm not a psychologist, but I've worked in enough integrated behavioral health settings to know that they can give these little micro doses. So for example, we know that if we can teach kids how to talk about primary feelings like sad, worried, confused, versus the behaviors that we see manifest from that, like anger, hitting, hurting, refusing, biting, kind of aggression, which is probably the presentation they would come to their pediatrician with, right? My child's angry, my child's hitting. Well, we know that a couple of things can ameliorate that. Are we giving your kids words to express feelings? So we have a little tool that we use called Yoki Feelings, where we teach kids how to talk about that squishy, yummy inside feeling, the sad, the worried, the confused. Or maybe it's a matter of teaching that parent how to do a time in or special time with their child to really get that high quality relationship, because we know that behaviors are simply a way of communicating, and usually what the child is needing is connection. So when we meet that connection need and we show parents, it doesn't have to be an hour of play for each child every single day. It might be having one-on-one time uninterrupted with your kiddo for 10 to 15 minutes at a time that will really help behavioral regulation, emotion regulation. So these are little things that we can kind of anticipate that parents need a little bit of guidance on, and then encouragement to follow through.
I love these examples, and I can see so many more. RJ, imagine, I know we talked about some young children to some extent. What about older children or teenagers? Are there specific techniques that work better with them?
Sure. And I think every age you have to think about what's the developmental challenge that child or teen is facing, and what does their day-to-day life look like, and what would be helpful in those scenarios. So one of my favorites, which I actually have stolen from Brene Brown, is the idea of a square squad, which I talk to a lot of middle school kids about. And in Brene Brown's work, she talks about how we as adults need to be really clear about whose opinion of us matters, right? And so she talks about taking a 1-inch square of paper, and on that piece of paper, you can write down the names of anybody whose opinion of you actually matters. Then when something else happens in the whole wide world, somebody on Instagram insults you or bullies you, somebody at school is mean, you have a teacher you don't like, you have two tasks. One, if you're hooked on that emotionally, you have to think about, why do I care if they're not actually on my square squad? Second, what would the people in my square squad say about this particular situation? And so for a lot of the kids, especially as they're starting to enter into middle school and social media and all these kinds of things, it's a tool to give them a little bit of a filter, like who gets into their brain and who doesn't, and how do you actually control who's influencing you? And I have to say that teens respond very well to that, because I think that in particular, middle school is very challenging in terms of filtering out who's going to influence you, what's important, who am I as an individual. And so having that kind of framework to think about, how do I actually separate out the important things for me to think about and the things that are maybe less important, they use that as a tool, I think, to really kind of help form their self-identity.
I think I'm going to go get one of those squares right now.
Well, our listeners couldn't see, but Amy actually held up a little pink square with little red writing on it. And I don't think we're on it, David. I don't think we're on the square squad
Why
yet.
would we be?
But it's a goal. Now I have a goal.
But Joanna, you're on my square. I just want you to know.
Oh, well, David, you're on mine too. And this is fun and such great advice for parents, but how do we as pediatric professionals grow the confidence to prescribe these healthy relationships? Because it seems way harder than writing a prescription for amoxicillin.
I mean, I encourage pediatricians to do this all the time, right? Which is just try one. Like maybe you try the square squad with some teenagers, or maybe you are talking about special time or time-ins with toddlers, or, just pick one thing that you really want to focus on, feeling expression, for instance, and get really good at that. Because I think what I notice is that at first it feels kind of clunky, and you might use somebody else's script, like RJ just walked you through square squad. And then pretty soon it feels a little bit more natural, just like probably the first time you had to talk about, a vaccine schedule as a new pediatrician, it felt kind of clunky. And then after a while, you kind of have your scripts down. The same thing is true with relational health. The more you talk about it, the better you get at it. I had a pediatrician that I was working with about that intervention I was talking about a little bit ago about Yoki feelings. Oh my gosh, he was like rolling his eyes. He's like, this is really cheesy for me. This is way deep into the feelings. And then later I called him to do a consult, and he said, that Yoki feelings thing, it really works. And I've gotten really good at it. And now I do it all of my 6-year-old well child checks. So he just picked one and got really, really good at it. And it just grew from there. And he saw, I think, also the responsivity that you get from caregivers and kids, like, this is really important.
Yeah, I was going to say, I think that's really what drives a lot of it for me, is the way the parents and the patients react to the interventions. If you think about most families can only remember 2 or 3 things out of a visit, right? So you have to be very selective about what you're encouraging them to take home and think about and do. But this is the thing that parents really seem to be the most hungry for. I think that parents and caregivers really understand that social emotional health is critical to their kids' school success and their development, but it's also where they're getting the least amount of support. And so when we're able to give them something concrete and tangible, the response is amazing. I've had families where I'm doing an intervention at every visit, talking about some little piece of relational health, and they'll come into the room, they'll sit down and they'll say, "What's today? What are we doing today? Tell me something more," because they're really hungry for these kinds of supports and practical things that they can do with their kids. And I would say that as a provider, burnout obviously is a huge issue in our field right now. And one of the things that really helps keep people from feeling burnout is having meaningful work. So work that is impactful and that is meaningful and that is helpful to people really helps to invigorate the practice. And so I feel more excited doing these interventions, I think, than I have felt doing a lot of other things in practice. And everybody that I've worked with who've done similar interventions feels the same way. It's an anti-burnout. So it's I think, transforming the way we do pediatrics, but also saving pediatrics to some degree.
Yeah, I would just add that I was working with a pediatrician and he was kind of putting his head around, some of these factors that we could use and guiding and helping caregivers. And he kind of paused and he said, "This is the most important medicine, isn't it?" He said, we could get rid of the car seat guidance or the bicycle helmet guidance or what have you, but this is really where we should be spending our time, is enhancing early relational health for kids and families. And it was a big aha for him. And he said, it means that I have to kind of unlearn a lot of what I learned in my residency program and in my medical training and dive more into this relational health model.
I love that. Well, I feel like we're building a great relationship here with both of you, but I'd love it if you could each leave us with a few takeaways to think about as we strive toward more connection in our practices. RJ, why don't you start?
For me, one of the big takeaways is really the idea of parallel process, that if I'm supporting a caregiver or a parent by strengthening my relationship with them, listening to what their concerns are, meeting them where they are in terms of what their needs with their child is, that teaches them some relational models for how to interact with their child as well. And so I'm using my clinical time to actually provide an example of how to manage behavior, how to manage supporting relationships and emotional regulation. And so really, the opportunity is to move out of a model where we are a one-way information flow, just telling parents what to do, but actually instead showing them how to do it in a way that's practical and meaningful and positive for both the caregiver and for the child.
And Amy, any last thoughts from you?
Yeah, I would just say you're already doing it. You already do so much anticipatory guidance. And if we know from the research that adversity and trauma happens to kids and families, and we know that resilience mitigates that, and the path to that is relational health, then it becomes paramount that we teach tools for relational health within the pediatric office.
Doctors Gillespie and King, thank you so much for joining us today.
Thank you.
Glad to be here.
If you want to hear more from this dynamic duo, pick up their new book, The Trauma-Informed Pediatric Practice, a resilience-based roadmap to foster early relational health, which you can find a link to on our website, aap.org/podcast.
Coming up, we'll look at the use of artificial intelligence and large language models in pediatrics.
David and I script the incredibly witty banter for all of these podcast episodes, but this time I thought I'd give us a break. So I typed into a popular AI search engine, write 3 lines of witty banter between 2 podcast hosts, and here are the results. So, what's the weirdest thing you've ever Googled at 3 a.m.? The next line is yours, David.
Oh, you mean besides how to escape a locked bathroom without breaking the door?
I thought mine was bad. How to train a squirrel to bring you snacks. And those are the lines. And in reality, real reality, David, I hate squirrels. But this was fun, and so is imagining the impact of a new article in Pediatrics, Large Language Models in Pediatric Education, Current Uses and Future Potential.
Well, we have on the show the two authors of that article, Dr. Srinivasan Suresh and Dr. Mitra Misra. Both are pediatricians. Dr. Suresh is chair of the Council on Clinical Information Technology and is currently at the Children's Hospital of Pittsburgh. Dr. Misra is at Texas Children's Hospital, part of the Baylor College of Medicine. Doctors, welcome.
Thank you for having us.
Thanks, David. Thanks, Joanna.
So large language models. Suresh, you're also an informaticist. Can you walk us through what these are and how they work?
Sure, happy to. I'll start with what artificial intelligence is. Sort of a simple and working definition of artificial intelligence is that it's a replication of human intelligence in computers. Going one step further, generative artificial intelligence refers to AI systems that can create new content, such as text and images and music or videos, but based on the data they have been trained on. So these systems use machine learning models to generate outputs that try to or mimic human-like creativity and problem-solving abilities. A large language model is a type of AI that is trained on vast amounts of text data and can perform tasks such as translation into different languages, converting into reading or literacy levels, summarization, and conversation. So in other words, all large language models are generative AI, but not all generative AI are large language models.
Some pediatricians are already using this technology. Mitra, in what ways are they putting it into practice?
No, LLMs have been used already to support continuing medical education. They provide instant access to information for pediatricians, such as guidelines, and they can actually help pediatricians study for board recertification exams by creating practice questions. You ask ChatGPT to make up a question, and it will make up a question for you. So it is being used already for a lot of really interesting types of education. And then some pediatricians are using it for patient education materials. So if you have a patient with a very specific disease process and you're not really thrilled with what's available on your electronic medical record to help the patient understand their disease process, you can actually ask whichever AI tool you're using to create something very specifically for that patient based on, specifically for their age or what type of maybe subtype they have. Or you can even change the language and put it into a language that the family speaks so it's more easily understandable.
I want to dig a little deeper in things that Mitra was saying. Suresh, how specifically can these large language models be used in teaching at academic institutions?
Sure. I'll give a particular example that Dr. Misra and I had the opportunity to highlight in the article. We asked a version of ChatGPT to create post-test questions at a medical student level related to learning about a procedure, specifically a lumbar puncture in a child. And it generated 2 questions with multiple choice answers, assuming the persona of a medical student. And then we went one step further and said, keep the same context. We're talking about procedural competency, doing an LP in a child, but increase the level of difficulty to the level of a pediatric resident. So the first 2 questions was, how do you position the child? Where do you insert the needle? Which was at the level of the medical student, but the subsequent 2 questions were about the safety of the procedure and complications, etc., which was at the level of a pediatric resident. So, as Dr. Misra mentioned a few minutes ago, a key advantage of these tools is the ability to get an output at varying levels of either literacy or training level, and in multiple languages. And that is something which we can do today without the use of ChatGPT and similar AI tools, but it takes much longer. So these really help us become more productive and efficient, not just necessarily in an academic setting, but also in community practice, teaching, and pediatric research.
And I'm curious about actual patient care. Suresh, is there a way that we can use this type of technology to help us make better decisions for patients and families?
David, yes, we can. One use case scenario is to use it for creating a list of differential diagnosis when we can input signs and symptoms, especially if it's a complex or chronic disease where we do not know the diagnosis yet, and get a list of possible diagnoses. Having said that, I don't think these tools are ready for prime time, so to speak, as far as direct clinical care at bedside. But in the area of patient engagement and patient education, they can certainly be helpful. And I have had the opportunity to do this in my practice, the pediatric emergency department here at Pittsburgh, and I'll give that example. And this is also outlined in the article, where at the point of care, I asked the ChatGPT app on my phone to come up with discharge instructions, post-care instructions for a 10-year-old child with asthma in 5 bullet points or less. So I have that output on my phone, and using the text-to-speech function on the phone, I was able to, play the audio, which the 10-year-old really liked because somebody was actually talking to him and not to his parents. And the output was at the reading and literacy level of the 10-year-old as to how he or she should manage their asthma at home. And that is just one example. This can be done for different age groups, specifically for parents, for other healthcare personnel, and in multiple languages.
Suresh, if we're using this technology in the clinic, should we also be putting out statements about the do's and don'ts of using AI in clinical care?
Absolutely. Just like any new technology, there are potential benefits and potential risks. And most of us may have heard the phrase hallucinations as it relates to AI tools such as ChatGPT, which basically means inaccurate statements, inaccurate output. Some folks call it fabrication. So that is certainly there. Although if we use it not for direct clinical care, but for patient education and engagement, the risk of harm is low. There still needs to be a human or a physician oversight to whatever output we get from these tools, whether it's for clinical care, patient engagement, teaching, or research. As these tools evolve, the accuracy certainly increases, the versatility increases, but there absolutely needs to be a human in the loop.
Well, it seems like the potential for this type of artificial intelligence is sort of endless. You both mentioned using it for discharge instructions and summaries. Can it also be used as a way to educate patients about common pediatric medical conditions? Mitra, are you already using it in this way?
We are using it in this way. Honestly, these AI tools can create very, very detailed or very simple instructions, explanations for patients and their families. And it is something that we have not historically been able to do without a pediatrician actually sitting down and writing them. And that takes a lot of time and a lot of energy. And most of us do not have that time in our regular workday. So the main advantage that we're all seeing from these AI tools is efficiency. In this time when we are all suffering from electronic medical record burnout, anything that can make our lives a little bit easier by improving how quickly we take care of tasks is a huge benefit for us. The reason that we are able to use these tools as pediatricians is because we are the content experts. All the concerns we have about these AI tools not being accurate, they are not important when a content expert is reviewing the output.
And Suresh, I want to pivot a little bit to academia here for a minute. Can we use these tools to crunch statistics or to look at data for us? What are the possibilities here in the world of research?
Yeah, absolutely, David. Even for a novice researcher, a medical student, or a resident, they could use these tools to refine their study design and to get a deeper understanding of, what should be the sample size. So how should I create the 2 arms of the study, etc. And for advanced researchers, such as faculty, it can still provide, value by figuring out gaps in care, and maybe that should be a focus of the research area. So certainly it has multiple practical applications in research, which is already being used by clinical researchers worldwide. If I may add to what Mitra just said, conversion of doctor speak, so to speak, which is what we see in our complex imaging reports and genomic reports, etc., to plain English will be very useful for our patients and families, and sometimes even to physicians. That is something which ChatGPT and tools do it really well, and subsequent iterations will only make it better. And even outside direct patient care in a hospital or clinic setting, if you think about the bills or the invoices which our patients get, the dreaded EOBs, which none of us would like to review in detail, ChatGPT can certainly convert that into much simpler documents so that they are more user-friendly and reader-friendly.
I feel like we are going to be interviewing these chatbots in a future podcast episode, but until they are ready to get on the mic, can you both give us a takeaway of how you see this technology shaping pediatric care? Mitra, let's start with you.
Well, I'm a clerkship director and an educator. And so for me, I'm focused on making sure that I'm teaching the students everything that they need to be a good, hopefully one day, pediatrician. But there are a lot of steps that they need to take to get to that spot. And we have already learned that AI is going to be part of medical education and medicine. And so we are starting to incorporate AI education into the undergraduate medical school curriculum. And educators like me are already starting to use these AI tools to create curricula, to create goals, to design questions for exams. And so it really is very quickly shaping the way that we are educating our students and residents.
Now, Suresh, what's your vision for the use of this in pediatrics?
Yeah, I'd like to make 2 points. For me, the biggest bang for the buck is in the area of patient and provider education, not just limited to physicians, could include nurses, pharmacists, social workers, etc. And just a simple conversion of complex medical charts, imaging reports, discharge summaries, etc., to plain English will have a lot of benefits. The other point I'd like to make is there is this wrong notion that artificial intelligence can replace physicians or replace pediatricians and healthcare workers. And I strongly believe that will not happen. An AI tool or a robot or a computer is not going to replace me as a pediatrician, because in addition to medical knowledge, we are good at social and communication skills and looking at sensory and nonverbal cues during the exam, etc. Having said that, I do feel that I may be replaced by a pediatrician who has a better understanding of artificial intelligence and computers and robots.
Well, Dr. Suresh and Misra, I don't think either of you are replaceable anytime soon, and I want to thank you both for joining us today.
Thank you for having us.
Thanks, David. Thanks, Joanna. Happy to be here.
To read the paper, Large Language Models in Pediatric Education, Current Uses and Future Potential, visit our website at aap.org/podcast.
At the end of every episode, we like to leave you with something positive or enlightening. We call this segment Say Ah. David, what's your Say Ah this week?
Oh, Joanna, I had one of the most meaningful interactions today that just is going to keep me going maybe for the rest of my career. I had a woman come up to me at the gym at the end of my workout and introduce herself and said, I don't know if you remember me, but you used to take care of my boys. And there was a time years ago when they were in for their wellness exams, and you turned to me and asked me how I was doing. And I don't know what it was, but I told you that I was struggling with alcohol dependence. And the way that you treated me, you just kind of focused on the boys and them and didn't judge me. That was the day that I quit and that I went into recovery.
Wow.
And the boys are great and I'm great, but I don't think I ever told you that. And I wanted you to know that. And I had tears, and that's what I need to know to get through the second half of my career, pretty much.
I have tears just listening. I mean, that's the dream, right? To help families, the whole family.
And we often don't know, and to get that kind of feedback is like, okay.
Yeah, and to have had that kind of relationship. And my Say Ah is about relationships, because the people in our lives matter so much. And it's that both sets of grandparents who we still have helping with the kids each took a kid for us during the week and left us with just the baby. And it was such an enormous privilege and a wonderful time to just have the baby that I have to give props to all grandparents out there who are helping take care of their grandkids in a big way. It makes such a difference. It really does.
That is huge. And the Zelda time. That is great. That's it for today's episode. If you like Pediatrics on Call, please subscribe on your favorite podcast app and help us spread the word. Follow us on Facebook and Instagram at Pediatrics on Call.
Pediatrics on Call is a production of the American Academy of Pediatrics. Our producer and editor is Ann Johnsos. Our audio engineer is Doug Nagel. Joe Puskars is our associate producer, and Susan Martin is our executive producer. Our theme music was composed by Matthew Simonson. Join us next week when we'll look at ways to prevent maltreatment of children in our care.
We'll talk to retired pediatrician and child abuse expert Dr. John Sterling. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. Thanks for listening.